So I want to thank everybody for coming to Grand Rounds today. On behalf of the Department of Internal Medicine, it's our pleasure to welcome Dr. Raghava Nagaraj, who trained in University of Buffalo in internal medicine after getting his medical degree from JSS Medical College in India. He is a hospitalist by training and also the medical director and chief medical officer of Lexington Medical Center. And he is both a faculty trainer in PERCC and a faculty in training for the Academy of Communication and Healthcare. So please join me in welcoming Dr. Nagaraj for his presentation.
Thank you, Adam, and thank you all for joining me this morning. Wanted to talk a little bit about some of the work that we're doing in relationship-centered care and communication here. I'm going to take you back to several years ago before I was introduced to this, working as a hospitalist. I got called about an admission for chest pain. It was a 67-year-old male who has hypertension, hyperlipidemia, diabetes, risk factors. He came in with some chest pain. There were some typical, atypical features. The emergency department called me saying that he needed to be ruled out at least before he goes home. He's just too high risk for us to send him home from the ED. So I accepted him as an admission, went to see the patient, started getting my history about his chest pain. But the patient wanted to talk about his back pain that he's been having for many years, and gently tried to redirect him to what I needed to hear in terms of the chest pain. That's why he's here. But he kept going back to this back pain and told me about his story of how his primary care physician had now stopped treating him for his back pain. He was getting oxycodones, and now, his PCP didn't feel comfortable giving it to him. And he had to go to a pain clinic, and he's on a limited income. He couldn't afford to have those things. He really needed to see his PCP because of all his medications he was getting. So I listened to him, and I tried to redirect him back to the chest pain, right? I needed to get that information. And towards the end of it, he asked me about his back pain again and if I could help him when he goes home with a prescription for pain medications. I knew that was coming. And I again tried to redirect him that he was here for his heart and not for his back pain. And finally, he got upset with me. It kind of became, I tried not to escalate it. I tried to de-escalate the situation, but it didn't work. Ended up leaving the room, had a bad feeling about this. I knew patient experience. I was going to be called, asked what happened, those things that happen, right? And the next day, I had two PA students who were working with me the next day, and one of them went to see this gentleman. And while we were kind of, before we go to the huddle, we were kind of going over what happened with this patient. The student was presenting to me. The patient said, "This is a 67-year-old, veteran of the Army. He had injury during his service for the country, and he's been dealing with this really difficult situation for a long time and has not really gotten the support he needed from the medical community. And it was a very difficult situation for him, is how she presented it to me. And that kind of gave me a different feeling about what this patient was probably going through. And when I went in to see him, his stress test was negative. He could go home. But I kind of acknowledged what the information the student had given me. Right? And he said, for the first time, he felt like somebody had listened to him. Somebody knew his story, and not as somebody with a patient with chronic back pain who asks for pain medication. So he actually left the hospital without a prescription for pain medicines, was thankful for the service he got in the hospital, and left. So what was the difference between what I did and what the student did? Right? That was the gap that I sensed that I had not been able to bridge during my encounter with this patient. So talk a little bit about relationship-centered care. I went through all the literature and read through all the definitions, and I didn't find one I liked, so I made up my own. So relationship-centered care is patient-centered health care in which the participants in healthcare is the provider. So I'm going to use this provider word today, and what I mean is anybody on the healthcare team. Right? It could be the physician, it could be the advanced practice clinician, it could be the nurse, it could be the physical therapist, it could be the nutritionist, the pharmacist. So I'm going to use the word provider to include everybody on the care team. So in which all the participants, all the providers in healthcare, the patient, the family, the community can effectively use relationships to provide better quality healthcare. And it's important to understand that these relationships are integral to the provision of the kind of care that we want to give. Back in 2006, the concept of relationship-centered care came to being, but it really didn't gain strength until much later. And then you have all these words of patient-centered care, relationship-centered care. How do all of these mesh together? What do you mean when we say all of these words? Traditionally, we used to be in a system where it was provider-centered care, right? It's centered around me. Whenever I could get to the hospital, whenever I could get to see the patient, whenever I had the time, whatever I felt was the right treatment. So things evolved where we had to look at what the patients brought. Every patient is unique. Their experiences are unique. What they go through is unique. What they can do is unique. And so the need to bring those patient experiences, the patient perspectives, their values, their cultures to provide better health care came into being, which is what we call patient-centered care. It created this feeling that the pendulum, as it swung from provider-centered care to patient-centered care, did it swing way too far? I would argue no, but a lot of providers felt that the pendulum had swung way too far towards the patient. And these relationships are a way to bring it back into the center. It's the relationship that is created between the provider and the patient that helps bring these uniqueness of the patients into perspective, but also the knowledge of the provider, the training of the provider to be able to develop a plan with the involvement of the patient to be able to provide the care that they need, that they deserve. And these relationships are therapeutic in the care and help as the medium of care delivery in relationship-centered care. An important concept is also the clinician's relationship with him or herself. So in the example I gave you, I walked away from that visit the first day feeling extremely upset with how things turned out. I was worried about what's going to happen. Is he going to complain? Am I going to have to answer for myself? I actually thought I provided good care because the patient shouldn't be on long-term opioid pain medications, but that sense of, oh, I've got to have to answer to somebody now for providing the right care kind of was going through my mind, right? But the next day, the treatment was the same. The patient didn't get opioid pain medications. The patient went home with some plan of having to follow up with the PCP and maybe a plan to that he would be taken care of within the system if people listened to him. But I felt so much better. So my relationship with myself was so much better on the second occasion. And that leads to a sense of self-efficacy, a sense of, that I provided good quality care to the patient. Though the care I provided was no different in terms of the treatment on both occasions. But the relationship that was created helped me look at the care that I provided in a different light. So that's where I feel the concept of the relationship between the provider, the patient, and everybody involved makes a difference in providing patient-centered care. So in 2006, when this was developed, Beach and colleagues talked about the principles of relationship-centered care. They ought to include the personhood of the participants, which meant that you've got to take each person in that care team as a unique individual, what they bring to the table, the baggage they bring or the positives they bring, all of those can influence the care that is provided. On the day I've had a fight with my wife, or on the day that maybe I just returned back from vacation, I would behave in two different ways. So my personhood is important to the development of the care. Affect and emotion are important. Most of our patients, especially mine, when I see them in the hospital, are going through some of the worst days of their lives. So there's a lot of emotion involved with it. I'll give the example of my interaction with my wife when she had a fight with her sister, right? And she came and complained to me. There was a lot of emotions going on. What I did was I told her, I thought she was asking me for a suggestion. I gave her a suggestion. You all know how that went, right? So not the right thing to do. So sometimes when our patients are going through the worst time of their lives and they're showing those emotions, our answers are, we're scientists, right? We work based on data. So when my patient with COPD exacerbation who'd had a horrible night got 3 or 4 albuterol PRN nebs along with the scheduled DNeb because she was in distress, tells me the next morning, I'm finding it really hard to breathe. I felt horrible last night. My answer usually used to be, but that's because you're having a COPD exacerbation, right? And that's just like how I answered my wife and my patient. I didn't connect. But if I had said, this seems to be really difficult for you. You know what? I'm going to listen to you. Tell me more about how your breathing is going on. And then maybe explained it. Maybe she would be in a better place to hear it. So all healthcare relationships occur in the context of reciprocal influence. So if I am respectful to my patient, I would get an equal amount or more of respect back from my patient. And the formation of and maintenance of genuine relationships in healthcare is morally valuable. So back then they felt that morally this is the right thing to do. Morally it is right to respect our patients and treat them with dignity and create those relationships. So we come from relationship-centered care. How do you provide relationship-centered care? How do you get from, did I want to get from where I was when I started and had that experience to where I want to be when I have a better experience? What did the student do that I did not do? And the gap was communication. When I trained years ago, I remember for my residency, we were given a book to read on communication. And we had a 30-minute discussion around a table regarding that book, and that was all the education that I got. And so communication is that bridge that we need to be able to do that. But what's wrong? We've been communicating for years, right? So what is the most common procedure any of us do? When I was first asked this question, I was thinking, as an internist, maybe the central line, right? I've done a few of them since I finished residency. I did probably one in the last year, right? Interactions with our patients are our most common procedure. In a provider's lifetime, about 200,000 plus encounters, right? So I'm going to challenge you to think about communication as a procedure. So I'm thinking back to my first central line. Before I did my first central line, I'd seen another resident put in a couple. The chief resident stood by me and he explained the anatomy, he explained the procedure, took out a kit, showed me all the things that were in it. And then when I was doing my first one, he stood over my shoulder watching it, giving me feedback as I was doing it. Everybody has heard that, don't let go of the guide wire, right? And every residency program, I bet, will have that story of that one resident who let go of the guide wire and all the horrible things that happened after that. So you're getting that constant feedback. But in communication, what kind of training, what kind of on-the-job feedback did I get? Not much. But like any procedure, communication has its risks and benefits. So taking you back to my story, my first story. The first time, you saw the risks that happened. The patient was upset. On the second day, you saw the benefits. The patient left feeling satisfied, feeling heard, although the actual treatment did not vary. And we received less training, practice, and feedback than other less common procedures. So my 25 central lines that I've put, I got 5 central lines where somebody was standing over my shoulder, looking at me doing it, giving me constant feedback. And I got none for over 200,000 communication procedures that I would do. So is relationship-centered care and communication of moral value only? Does it actually lead to better care? Right, so everybody's familiar with IHI's triple aim. So, they suggest that any intervention be able to improve population health or care for people, improve the per capita cost, reduce cost of care, and also improve experience of care. Right? And then a lot of entities are talking about the quadruple aim, well-being of the care team too. So let's look at relationship-centered care and communication in the light of IHI's triple aim, or maybe even the quadruple aim. Before I go to that, we'll talk a little bit about patient experience. And my first view of patient experience was that, patient is going to complain about me. I'm going to be called up. And in these scores, right? How many of us think about patient experience like this? It matters. The bottom line matters. I'm going to, it's whether or not I make 10% of my pay based on, or maybe not 10%, 3%, 4% of my pay based on those numbers that our patients give us, right? And we think about, first thoughts come to mind, the people who maybe get pain medicines give us better numbers. I've heard this, I've said this, I've heard this a lot, right? So what have some organizations defined patient experience as? So Society of Hospital Medicine says everything we say and do that affect our patients throughout their thoughts, their feelings, their well-being. So all the interactions that we have with our patients, everything that we do in terms of their treatment, everything that affects them. And then the Bell Institute said the sum of all interactions shaped by an organization's culture that influence patient perceptions across the continuum of care. So kind of broad definitions, right? So I'm thinking about, it's not just how they feel, it's not just the satisfaction, it's also about the quality, the safety. When somebody comes into the hospital seeking care, how do they end up with? What do they get complications that would reduce their experience of care? Do they have good outcomes that would improve their experience of care? So everything, the total continuum of care that they receive in the hospital or in an outpatient visit, that is the experience of care. So I said, why not we think about this as patient experience? Right? We say this every day. And it talks about safety. It talks about respect and care. And again, I'm going to challenge everybody to think about this as patient experience when they leave the room. So in terms of patient experience, what has relationship-centered care done? So the way we measure patient experience, unfortunately, is through those scores, those boxes. So at Wake Forest Baptist Health, I'll talk to you about the intervention that we've done. A lot of you have attended PERCC, the training course for relationship-centered communication. So 117 physicians with an office-based practice had a significant increase in the CGCAP's composite score for quality of physician communication after undergoing relationship-centered communication training. And then at the University of Maryland, similar course, similar improvement in their, significant improvement in their quality of physician communication scores. So that's what relationship-centered care and communication can do to patient experience. There are other organizations. At Cleveland Clinic, they did a similar course which improved patient experience. There are other studies in outpatient practices which have shown improvement. And an inpatient study in hospital medicine at the University of California in San Francisco showed that patients felt more cared for when they were shown empathy, and there was relationship-centered communication. So there's a lot of studies that are coming up which show the improvement. Most of them have been in outpatient settings. We need more studies in inpatient settings that would continue to show this trend. And then going to population health and cost. Effective communication showed improvement. So there was one study, there was a study in which African American patients with poorly controlled hypertension were divided into two categories. One half received care from physicians who were trained in communication, and they had much better adherence to taking their medications. They had much better control of their blood pressure. Same thing in diabetes. HIV, that's a tough population to take care of. There's data that shows that patients had better adherence to their medications when they were treated by a provider who had communication training. Medically unexplained symptoms. So there were two randomized control studies done on patients with medically unexplained symptoms. That's one of our toughest population of patients to treat. There was improvement in their symptoms when the provider was trained in communication. Irritable bowel syndrome and chronic constipation. Again, another tough population to treat. In a study where residents were trained in communication, there was a significant improvement in readmission rates for congestive heart failure. There was also a study two studies which showed improvement in patients' pain control in outpatient settings when the providers were trained in communication. So all of these show that there is improvement in both, can show potential for improvement in both population health and in cost of care. Imagine the cost of care for patients with medically unexplained symptoms when their symptoms are not controlled, right? It escalates. Readmissions for CHF is an important cost. What about well-being of the care team? So I've put up two graphs that show the degree of the problem we have. It's almost a public health problem now. Burnout in physicians and nurses and advanced practice clinicians, it's everywhere. 54% of doctors say they're burned out. There were studies where residents, more than 50% of residents claimed that they had symptoms of burnout or symptoms of stress and exhaustion. 59% of doctors did not recommend a career in medicine for their children. So we came to this as a noble profession, right? And we don't want our kids to go into this because we don't want them to go through this. So there was a study which actually asked providers what the reason for their burnout is, and some of those listed, some of the top ones are listed there. I included the ones where communication can be of help. Too many difficult patients. Like, I remember days when I look at my list and I'm like, who do I put last on for the day, right? And there would be like 5 patients or 6 patients that I wanted to see last because I knew it was going to be a difficult interaction with them. And some days when you look at your clinic schedule, you'll see somebody at 11:30 in the morning or 1:30 in the afternoon, and you know your day is shot because it's going to be a drawn-out, long, difficult visit. Not enough time for patients. I do 15 minutes for a patient. How do you get everything done in 15 minutes and get your note typed? Cannot provide good quality care. The system works against me. The system prevents me from providing the care that I want to provide. Lack of professional fulfillment. So the feeling I had the first day in that story when I took care of the patient, I felt like I didn't do a good job. And then difficult colleagues or staff, right? So we looked at how communication can help with difficult patients. It helps improve symptoms of patients with medically unexplained symptoms. It helps patients with HIV take their medications more regularly. It helps in treating patients with chronic pain. Cannot provide good quality care. That's more self-efficacy. I don't know that I can provide good quality care given the time I've been given the difficulty of patients I'm seeing. Maybe it can make a dent there. Difficult colleagues and staffs. So communication with patients, I told you how I could use some of the concepts with my wife when I talked to her. So maybe a colleague who's having a difficult day needs empathy. They don't need solutions, right? So, so a lot of these things are things which communication can help with. And a system-wide relationship-centered communication skills training, this was done at Cleveland Clinic, where all 1,800 faculty went through this training program, and it showed improvement in patient satisfaction scores, but it showed a more significant improvement in provider, in physician empathy, in their self-efficacy, and the reduced burnout. So 6 months after the training, the reduced burnout was sustained. And then a participation in a mindful communication program was associated with short-term and sustained improvements in well-being and attitudes associated with patient-centered care. So physicians who went through this these were outpatient physicians, primary care physicians who were providing care, and they had improvement in their attitudes and feeling of well-being. It's shown to lead to better collaboration amongst the healthcare team. So communication training for all members of the healthcare teams improved collaboration. Reduces malpractice claims. So actually there was one study which looked at the physician's tone of voice, the surgeon's tone of voice, and his risk of being sued. And it showed that the tone of voice can influence that. But there's a lot of other studies which show that relationship-centered communication, effective communication, reduces the risk of a provider having a malpractice suit. So during our training course for communication, these are the core concepts that we have in terms of relationship-centered communication. You invest in the beginning, you invest in the end, you obtain the perspective of the patient, and you show empathy. So investing in the beginning, you're trying to create that rapport with your patients. You do some small talk. You make sure you acknowledge them by their name. Make sure you know a little bit about them. That would help you connect. Make sure you introduce yourself. So we work in a system wherein we have teams which are big. And then there are several different teams which see the patient. The patient may have 3 different consultation teams which are visiting the patient. Oftentimes our patients and families can't recognize who's who. So introducing, acknowledging them is important. So you invest in the beginning. Obtaining a list and negotiating an agenda for the visit is helpful as well. Exploring the patient's perspective. So why does the patient feel the pain is happening? What is causing the pain? What do you think is happening? What do you think can help you feel better? So knowing what the patient is bringing into the visit is helpful when we create a plan for treatment. Expressing empathy. We've talked a lot about empathy and how it's helpful. Patients are vulnerable. They're having a lot of strong emotions. So exploring their emotions and expressing empathy verbally and non-verbally is extremely helpful in these situations. And you invest in ending the visit where a patient is involved in creating the plan of care and teach back. A physician who works here told me the story. He and his wife is also a physician, that his wife had a surgery, had gone to the surgeon for post-surgery follow-up visit. So it was the PA who works with the surgeon was doing the dressing change and was explaining how to do the dressing change, right? So after explaining how to do the dressing change, doing it, they explained it again to make sure that the patient understood. And so they go back home, and that night they had to do the dressing change. Like, what did they say? Does the gauze go first, or does this go first? Do I have to soak it in water, right? So teach back is an important part of what we do. My usual style has been tell it once, your spiel that you've developed over years, tell it once, tell it again, and tell it for the 3rd time. They should definitely get it if I tell it 3 times, right? So trained physicians sometimes can't keep up with what you say. And, a lot of times adherence is not perfect because patients probably don't understand the plan that was created. So teach back and closing the visit. So these are kind of the core concepts of relationship-centered communication. We'll talk a little bit more about empathy because of how important it is in the things we do. I often tell people when I work with patients, if I don't use any of the other skills, if there's one skill I can take and use in every single patient visit and make an impact, it's empathy. It's the ability to share with another person's feelings and emotions as if they were your own. Like standing in their shoes, feeling what they're feeling, knowing what they're knowing. That's empathy. A lot of times we confuse sympathy with empathy. Oh, I'm sorry you're going through it. Not truly empathy. It's that's more sympathy. I feel bad for you. But empathy is more, I feel what you feel. Empathy by itself, there's data that shows that empathy by itself improves clinical outcomes. So there was a study where they looked at physicians' use of empathy and treatment of diabetes. Patients who had physicians who used empathy had much better outcomes in their A1C. Their A1C was better when the physician showed empathy. More accurate diagnoses. Patients often are vulnerable and don't tell us their whole story unless they feel like they're being respected, they're being listened to. And using empathy will help them be able to do that. It increases adherence to treatment plans. Empathy reduces duration of clinical encounters. So one of the problems we have is, how can I fit all of these things into my visit when I already feel rushed? That's a big question that comes up all the time. I told you I don't have time, and you're asking me to do all of these things. If you attend the course, you'll see that all of those things are actually part of what we truly do, and use of empathy actually reduces the amount of time that you would spend with a patient. Going back to my first story, the patient who kept going on and on about the back pain because he felt I hadn't heard it. I hadn't understood what he was suffering through. Had I shown empathy, we probably could have moved on and gotten the history about the chest pain much easier. So showing empathy actually reduces the time that a person spends in a clinical encounter. And there's been a lot of data that shows that it improves patient satisfaction scores in outpatient and inpatient worlds. So there's all of these good things with communication. Well, why don't we do it? I said soft and mushy, right? We don't like soft and mushy. Give me data that shows that starting this medication will help. I'm more amenable to doing it than to say, if you show empathy, if you're empathetic to the patient, it helps them get better. To me, before I went through this journey, that would have been a difficult sell. And I'm sure it is for a lot of us. I remember residency training, right? The thing of the day was who did the most admissions. You hear these stories, these heroic stories of these residents who have done 12, they did 13 admissions one evening in a span of 8 hours. Or this person always is able to. So we go through training wherein heroism is, and we create these versions of ourselves, and then through life in this hectic pace where soft and mushy has no place in what we do. It questions our practice for years. We've been doing this for so long. Have I been doing things wrong for so many years? Or could I have done better all these years? And I've been communicating for all my life. What do you mean I need to do something differently? Payment models need reform, right? Sometimes the way we have things situated, that readmission sometimes may mean more money for the system than preventing a readmission. So payment models need reform to where population health, reducing cost, actually means something to the bottom line of an individual provider. We have lots of other competing goals, right? RVUs and other things that we need to improve. Healthcare is constantly changing. There isn't a month wherein we have one more thing that comes up, creeps up on our agenda. So how do we make this a priority? How do I spend time going to a full-day workshop and then kind of having some feedback and having some learning? I did my training years ago. Do I need to go through something like this again? How much time is it going to take me to get better at this? So there are other competing goals. And it needs ongoing evaluation and feedback. Do we have the resources? So we have a course. We've shown that something might improve, but how can we get better at it? Do we have the resources within a system to be able to provide ongoing evaluation and feedback to providers? So wanted to continue and wind up talking about what we're doing at Wake Forest today. So right now, faculty, network physicians, advanced practice clinicians, resident fellows, medical students, PA students, nursing leaders are in some way involved in communication training. So we've been trying to spread training and communication to all these groups. So the program to enhance relationship-centered communication, which is what we call our version of relationship-centered communication training. It started in 2015, November of 2015, in collaboration with Academy of Communication and Healthcare. We started off with a big bang. About 35 of our physician leaders went through this training program. I remember Dr. High was there, Dr. Howerton was there, and then we decided to take this journey. We had the Train the Trainer initiative. Currently, we have 8 trainers, and we're pictured in there. We do this about anywhere from 2 to 4 sessions a month, and we usually do it with groups of 10 to 12 participants. It's a mixed group of physicians, APCs, residents, and nurses. 6.5-hour CME is provided. It runs from about 8 in the morning till about 3:30 in the afternoon. As of 11/6/2018, we had trained a total of 868 providers, 465 physicians, 172 APCs, 177 residents and fellows, 54 nurses, counselors, chaplains, etc. This is some of the data that we've gotten over time with the training program that we've done. 117 physicians who have an outpatient practice who we were able to study for 6 months before and 6 months after their training were looked at, and we looked at the top box for CG CAPS, composite score, quality of physician communication. So it's entirely related to the communication of the provider. So there was a significant improvement in their scores from before to after. And then these are some of those questions which come under the physician communication domain, which, again, you see that except for one, there was significant improvement in all the other domains of those questions. So who actually improved? So when we looked at the 117 providers, we said, so which group of providers improved? Was there a trend in it? So when we looked at it, we had 54 physicians who were below the mean. So the mean for Wake Forest as a whole, we looked at all the 400 plus physicians who had an outpatient practice, and we looked at all the physicians below that mean. They had a significant improvement. And the providers who were above the mean kind of stayed the same. So we saw that the improvement was mostly in providers who had below the mean. And it's possible that the providers above the mean already are using some of these concepts in their care today. And, okay, they improved. There was significant improvement. Is it of any consequence? So when we looked at the increase of the whole group, took the total of 117 providers, we saw that the top box, the percentile ranking within all of PERCC. So this is all of the physicians who have outpatient practice in the country, went from the 28th percentile to the 41st percentile. So that was a 13 percentile point increase in, and then the same thing when we looked at the 54 providers who were below the mean, there was a 13 percentile increase in their scores. For residents and fellows, I showed that 177 of them had gone through the PERCC training. In addition, we've been working with individual departments at having sessions for their residents and fellows in a situation and at a time which is convenient for residents and fellows. We've already worked with emergency medicine, internal medicine, ophthalmology, dermatology, and we're planning one for pediatrics in 2019. And then when these residents and fellows are rounding with some of our trainers who are part of our faculty. They are also getting on-the-job training and feedback. So Dr. Peter Lickstein has developed some of these, has translated some of these skills into bedside teaching. So, and then student education, clinical skills 1 and 2, which used to be called doctor-patient relationship, or DPR, now has the same concepts as the relationship-centered communication course that we teach. So think about students learning the same language that we're talking about. I heard a story from an oncologist when I was teaching one of these courses that the oncologist was working with a medical student, and they had a situation where they were actually going to break bad news to a patient. And they talked about how they could use empathy. We used the acronym PERLS for use of empathy. So they actually planned before they went and saw the patient and talked about what pearls they could use, and went in and worked with the patient. So imagine if everyone in our organization is speaking the same language, and how we can help each other, how we can give each other feedback. You don't need those additional resources. We could be our own resources as we move towards this. And and the communication course for the PA school, which used to be called Common Ground, that now includes a lot of the terminologies that we use in our relationship-centered communication course. So they're being trained in a similar fashion. And when they're doing clinical rotations with faculty who've been through PERC, that is reinforced, like I told you about the oncologist and the medical student. In hospital medicine, we're trying this. Hospital medicine at Wake, we have some of the lowest scores, unfortunately, for our provider communication. So we're trying out this where we use an abridged version of what we do, an abridged version of relationship-centered communication, again so it's called AIDET, which stands for Acknowledge, Introduce, Duration, Explanation, and Thank You. So 5 small things that you could do in any patient visit, and make sure you do, and use the whiteboard for communication, and then use PERL statements for empathy. So we're trying to do that, and we're going to see how that affects patient experience scores on the inpatient setting. So that sums up all the work that we're doing today. Special thanks to Dr. Lickstein. All of you know Dr. Lickstein. This has been his life's work, and he has contributed a great deal to bring this to Wake Forest. For me, Dr. August Fortin, who's a professor of medicine at Yale, and Dr. Calvin Cho, professor of medicine at UCSF, who've been great mentors to me. And Calvin was actually one of the trainers from ACH who came and trained us. And doctors Marsha Wofford, Jennifer Helderman, Andorra Bass, Greg Waters, Rich Widerski, and Billy Rice, who are all our faculty trainers. And Colleen, want to give out a shout out to Colleen. I think she's there at the back. She's been amazing at spreading this message and helping us take this from where we are. And she actually helped me a lot in some self-awareness about my own communication barriers early in my career. And then Amanda Smith, Julie Barnes, and Susan Compston. So thank you all for everything you've done for this. I would like to end there. Take questions.
Raj, very nice talk about an important topic. Abraham Verghese, has written a lot about the patient-physician relationship, and one of the phenomena that he's described is the introduction of the eye patient. And that traditionally patient care was a dyad between the patient and the physician. And Verghese talks about the introduction of this third element, the eye patient, which is, the electronic medical record and the time that providers now spend, with the electronic medical record. And he talks about that as really a diversion and challenges to sort of, building relationships with patients. I was wondering if you had thoughts on, strategies for trying to mitigate the impact of what, Verghese calls the eye patient.
Sure. We talk about this in the full PERCC course, but it is a big deal today, using the EMRs. I've been in some clinics where your back is to the patient when you're on the computer, right? And a lot of us have, we need to do our notes while we're working with our patients. So a few strategies, a few tips we talk about is engaging the patient in the use of the computer. If you're looking up labs or you're looking up an X-ray, make sure the patient is engaged. And, if you have a way of turning the screen towards the patient and as you're looking it up, also showing it to the patient is a good way to make sure that they're part of the communication. Sometimes asking their permission to say, hey, if you don't mind, while we're talking, I'm listening to you, but I'll be working on my computer, making sure I don't forget what you're telling me. I need to make notes for that. So making sure the patient understands what you're doing. And those emotional moments when they come up, maybe the time to stop typing, eye contact, make sure the patient gets your full attention and has a feeling that you're actually caring for the patient. Those are some of the things that we talk about.
This is a great topic, and I'm really glad it's coming out to the fore here. Do you have a sense how one learns through the course of a career to adapt to these needs? Is it better at the beginning or is it better at the end? In other words, are you continuously learning along the way?
So I can tell you my experience. I think it's an ongoing process. I'm glad that I got to it fairly early in my career because there were things that I didn't have to unlearn. But use of these skills are dynamic. Every patient is dynamic, and use of these skills are dynamic. So I think it's a learning process that you keep getting better at. And you get thrown into situations wherein, which are unique, where maybe the family is upset because of something, the patient has a problem that you can't solve. So it's an ongoing process, and it's never too late to get involved in it.
Thank you.
Thanks, that was really good. One of the things I'm worried about is that we do these day-long sort of conferences, and it's once, and it was 3 years ago, and we all felt really good when we left. Mm-hmm. And one of the things I'd like to sort of learn more about is, in the course of our usual teaching conferences, we have conferences every week in every one of our sections. Do you see that there's a role for continuing smaller bites or smaller communications training within the context of those? And then what would you suggest we do? Like in a subspecialty section, we have conferences on interpreting X-rays or something like in our pulmonary group. But I think if you looked at each of the sections, you'd find similar types of conferences, but yet we don't have one specifically on communications training or maintenance of skills. What are your thoughts on where we should be going as a department in that regard?
So, thanks, Carl. That's a great question. We're actually thinking about a PERCC 202 version, which is smaller, condensed, and looks at specific topics. So we could talk to departments and see what are their difficult patients, what are their difficult interactions. Maybe it is focused on patients who come in asking for opioid prescriptions. Maybe it is working on breaking bad news. Maybe it is, so we can pick certain smaller topics and condense it into a 1.5 to 2 hour workshop, which would be more palatable and easier for people to invest time into. A big thing we do in these workshops is skills practice. So the theory is very little. The didactic is less than 10%. 90% is skills practice, which is where we think the meat is, where you practice, you try out these skills, and you learn what works, what doesn't work. And so about an hour and a half or to 2 hours is probably the shortest we can make things.
Any other questions? Okay, well, thank you very much, Dr. Nagaraj.